Let me
Hello.
just.
Good morning, everybody. Welcome to another Friday RLR VMR. We're very excited for this one. I'm slowly but surely waking up. It's a little earlier than our usual time. But we're very excited to welcome our first time case presenter, Amma. Amma, tell us a little bit about yourself, please.
So I'm a second year resident at AUGA Piedmont in Georgia. I'm actually friends with Yusuf Salawi, who's a part of this podcast. So I'm really excited to be here today with you guys.
Amazing. Tell us a little bit about yourself. What's your background? What do you like to do?
Okay, so I'm originally from Lebanon, so I moved here 3 years ago. I'm interested in infectious disease.
Nice.
And so I'm planning to apply for fellowship this June.
Amazing.
And then I love to travel a lot. So I've tried to tackle most of the states in the US, but I'm far away from that.
Amazing. Where in Lebanon are you from?
I'm from Tripoli, but I live most of my life in Beirut.
Nice. I'm from Zahle. Uh,
Ah,
yeah, born and raised for a little time. Then my parents left. I actually grew up very far away. I see Prof. Rez is here. Look at that beaming smile. Hi, Prof. Rez.
I have a question for you, Amal. So, can you pronounce Robbie's last name for me?
Rabi.
So it's Geha. How do you pronounce that?
Oh, Jaha.
Finally, guys.
Let's hear it, Prof.
That
Rez.
was 6
Here.
years in the making.
And and I think we call him Rabia, right?
Rabia Jaha.
Jaha.
Pretty good.
Rabia Jaha. I'm just trying. Anyways, take the mic away from me, Robbie.
Well, we're very. Thank you
Oh,
for.
you kick off the first aliquot.
No way, Prof. Rez. No way. Amal, thank you so much for joining us. We're very excited, and thank you for being the only person here who can absolutely perfectly pronounce my name. It's an honor. All right, take it away whenever you're ready.
Okay, so I'm gonna do the case a bit different today. I'm gonna start with my physical exam because this is how I saw this patient. It's a real patient that I had to change a lot for the identification purposes, but I saw this patient when I was doing my ICU rotation. So I saw a 60-year-old female. She was obtended. So at the time of my exam, her vitals were temperature 101.5, heart rate 104, blood pressure was 119/64, respiratory rate was 22, and SATs were 60%. So we had to emergently intubate her. At the time of intubation, she was found to be obtunded. Her pupils were constricted, reactive to light, and we intubated with a gydoscope. So when we were looking in the gydoscope, she had copious secretions during intubation. Cardiovascular exam showed normal rate, regular rhythm, no murmurs were heard. After intubation, she had adequate air entry and no other lung sounds were heard. Abdominal exam was unremarkable, soft, non-distended, non-tender, had normal bowel sounds. And for her neuro exam, she was completely obtunded. No gag reflex was noted during intubation. And then her Babinski's were positive. And for extremities and skin, there was no clubbing, cyanosis, or edema.
Wow, what a start to the case. Oh my gosh. If Rabia wasn't awake, Rabia Jaha is now awake. Alma, can I just ask you one question?
Yeah.
What's the context of all this? Is she in the hospital? Is she brought in by an ambulance? Do you know what preceded this?
Yeah. So she was in the hospital. I was in the ICU. She was transferred emergently to the ICU for urgent intubation.
Got it. That's really helpful. And I know we'll get more information as to why she was in the hospital, but immediately we can start breaking down this problem.
Mhm.
And that's a problem of obtundation or completely absent mental activity. And that differential diagnosis is all dependent on the tempo of the patient becoming obtunded. So, for example, if someone was fine, like I'm talking to you right now, and mid-sentence, God forbid, I were to pass out, that means this pathologic process took seconds to occur. And something that takes seconds to occur prioritizes a vascular insult like a hemorrhage, electrical discharge like a seizure, or some type of toxic metabolic encephalopathy like hypoglycemia. Now, compare that to someone who's in the hospital and slowly over time, they're becoming more and more somnolent. Now, all of a sudden, you're not worried about the seconds to minutes. You're more worried about the hours to days or an acute process. And so now we start thinking about inflammatory stuff like infectious etiologies. There's just one caveat, and that is toxic metabolic stuff can happen during any time course. It's almost like comparing atrial fibrillation versus sinus tachycardia. AFib can happen like that, and SVT happens like that. Sinus tachycardia builds up. In this patient who's obtunded, we have other clues to make progress as to what might be the etiology of their decreased mental status. And that is the vital signs and the neurologic exam. When someone is febrile with decreased mental status, you should prioritize infectious meningoencephalitis, but realize that someone might be seizing and have a infectious foci somewhere else. So there's many ways you can put this together, but you should prioritize the brain. And there are non-infectious causes of confusion and fever like neuroleptic malignant syndrome. So this doesn't mean it has to be infection. But Robbie, you know what I found most interesting? Now, I'd love to hear your thoughts. Two things. One is this neuro exam, like the fact that the patient had no gag reflexes. Where did those gag reflexes come from? These are our brainstem where the cranial nerves exit. And so if we were even worried about an infectious etiology, all of a sudden I'm concerned, could this patient have like a basilar, like lower level meningitis? The Babinski being positive, again, that's not a sensitive marker, but it is quite specific with a high positive predictive value for some form of CNS infectious process. But I just wonder with these brainstem abnormal reflexes, if we can prioritize, and the Babinski being positive, prioritize a basilar type of meningitis, and then because she's obtunded, add on encephalitis, and then the copious secretions that was noted along the intubation makes me worried. Is there something happening in the lung that's also, traveling to the brain? Like you said on that one last episode, an underlying process affecting two organs, an external process affecting two organs, or a direct connection. But I'm just right now worried for the brainstem, infection, and the lung. But I would love to hear from you, Raul, because this is such a rich aliquot.
I know I completely agree with your analysis, Prof. Rez, and I think it's amazing how Amal is taking us to a place I don't think we've ever been on VMR in the 4 years of just like an acute, severe situation from the get-go. And I really appreciate this exercise. And there are a lot of management things and the diagnostic thoughts that Prof. Rez, I can't add anything to, quite honestly. I think it's just interesting to reflect now that he shared all that, that we essentially have a CNS and a pulmonary syndrome before us. And the question is, how do you connect the dots? And I think at first glance, it's very easy to say that, somebody is requiring intubation, so their lungs aren't going so well. And we see a lot of patients with pulmonary problems get confused. But I think here, the degree of encephalopathy compared with the degree of pulmonary dysfunction gives us insight into which way we might lean. This person is obtunded, and yet she is able to be ventilated and oxygenated with relative ease. And so when you're comparing and use the law of proportionality, you're like, huh, brain is all down, lungs are kind of down. And then when you understand how the lungs are down, they're down in the context of dropped gag and cough reflex. It's very easy to see how a sequence of events of severe neurological catastrophe led to inability to protect the airway, led to pulmonary processes. And the fever here is of paramount importance because it forces us to consider infectious considerations, but it may be a profound distractor in the face of chemical pneumonitis. So my leading hypotheses now are that if this fever is new and has not been documented in the hospital before, then the sequence of events becomes even more clear that this patient in the hospital developed a neurological event that led to a pulmonary syndrome. In stark contrast to community-acquired pneumonia the other way, or infectious meningoencephalitis, where a tail of a few days would be expected to be present. And I'd make an inference in this case, and the inference being that the severity of her obtundation correlates with the time course. Unless you're in an unwitnessed scenario, it's impossible to get this sick. It's impossible to get this sick over a period of time. The only way a patient in the hospital would be left to be obtunded is if the patient didn't give us enough time to help her not be. So I would venture to guess that the time course here is fairly acute, if not hyperacute. And so I'm right there with you, Prof. Rez. The first checklist is a substance. Did she get an opiate or did she get insulin? And after that first check of a substance, is there a stroke, especially in the posterior circulation? So I think the next steps for me would be, after stabilization, would be, is there a role for Narcan? And that seems to be not at play given the respiratory rate and the pupil exams, which I thought was normal. And then, honestly, straight to a CT. And in this instance, it would be very, very important to not just get a CT, but a CTA angiography looking for a basilar thrombosis. All right, Amal, tell us more, please.
Okay, so after we stabilized the patient, we went back, took history from the primary team, and we did a bit in the chart. So this lady had worsening headaches for the past 2 months, and the headaches were intractable. She saw her primary care doctor, who did like extensive workup and had a prior CT brain, like 3 months prior to our admission to our facility, and the CT brain showed the hypodensity in the cerebellum. Then her PCP did like a pan CT, and it showed like cysts in the liver, spleen, and left kidney. She was able, per primary team, to give the whole history, and she said that her PCP gave her steroids, a course of steroids, and she was taking it. The only other thing she complained of was nausea, vomiting, and poor oral intake. And per primary team, she was in the hospital for 2 days prior to transfer to the ICU, and she was doing fairly well before this acute decompensation.
Very, very intriguing. Well, you've given us a history that there's a tail to the syndrome, and that tail is neurologic in dimension. I'm just curious, was it the headaches that brought her in do you know what her, she just came in because the headaches got bad, or?
The headaches, so she saw her PCP gave her steroids, and the headaches kept getting so worse. In the past 3 days, she couldn't sleep because of the headaches.
Understood. Okay, terrific. Yeah, what I'll try to do is just reflect on the headaches and pass the mic to Prof. Rez to reflect on the systemic aspects and the steroids. And I think, whenever we're taking care of patients with headaches, we're often trying to figure out if the headache is identifiable to a very specific pathology or whether it is an epiphenomenon of a syndrome. And most of us have experienced headaches as an epiphenomenon of a syndrome, no different than we've experienced fatigue or body aches. And the question here in this case is there a secondary trigger? And I think that becomes evident now that, of course, there's a secondary process. But I think that whenever you're trying to sniff out a secondary cause of a headache versus a primary cause, it sometimes is actually very easy. whenever a headache is accompanied by a very specific neurological sign like motor weakness or sensory abnormalities or meningismus, or prominent systemic symptoms, it's very easy to be like, okay, I'm very worried about this headache because the patient's weak or the patient has a stiff neck. It actually becomes a little bit harder when the headache is there by itself. So while you've heard of many different ways to approach the red flag symptoms for a headache, I don't know if that's effective. I think the most effective way is just to be like, well, is it obvious or not? And when there's secondary accompanying features that make the headache very, very concerning, you're done. The hard part is how do you sniff out a headache syndrome that's concerning, but your only diagnostic space is headache, headache, headache. The patient has nothing else going on. And that's where it's important to track the 3 T's. Has the patient had trauma? Is the patient on a thinner, blood thinner? And then finally, the most important T, timing. Does the patient have a hyperacute headache going from 0 to 100 in seconds? Or does the patient have the exact opposite, an unrelenting headache? All the headache syndromes that are idiopathic in nature terminate within a specific period of time. There are exceptions to that, of course. The entity termed status migrainous is an example, but none of those are diagnoses you can make up front. The final T, the fourth one I forgot, is triggers. If you can make your headache come and go with anything you do, then you don't have a primary headache syndrome, you have a secondary headache. So if I can make a headache come on if I lie down, or if I can make a headache start under my control if I Valsalva, that's a problem. So let's summarize the red flag features of a headache and then apply it to this patient. The easy part is when a patient has a prominent extra headache signature over neurological signs, high fever, so on and so forth. The hard part is when it's just a headache, and you have to listen carefully for what? Trauma, thinners, timing, and triggers. And here the red flag is the timing. This patient has an unrelenting headache syndrome. This is a secondary headache until proven otherwise. And now we have to dive into what that means. And I'll pass the mic to Professor to reflect on that.
I love the T's. Never heard that one. I thought if you would keep speaking, we would hear a fifth one add to the menu of options. And by the way, I'm surprised Robbie didn't make fun of me for this. I mistakenly, when you said Babinski, I thought you were saying Brzezinski for meningitis, but you said Babinski, correct? Okay. So that's just finding upper motor neuron sign, which really we're in the CNS, you know, and I love that approach to secondary headache, meaning putting us on the path to a secondary headache syndrome. The one thing that's really important, you have to ask, like, when would you give steroids for a headache? Like when? We know for the primary headaches, you really shouldn't be giving steroid, the migraine, the cluster, the tension. And for the secondary headaches, I can only think of one real cause, well, 2 causes. One is giant cell arteritis. When you go above the age of 50, especially when as your age advances, you're at risk of GCA. And that can be such a tricky diagnosis to make. When it's presenting like the textbook, it's straightforward, but it doesn't always present like the textbook because the vessels are throughout our bodies. And if you inflame these vessels, you can get a myriad of symptoms. The second time I can think of steroids being used is if someone has some kind of edema in the brain from a mass, and you want to decrease that edema so the patient doesn't herniate. But the other causes of secondary headache, it really comes into 3 buckets. And all you need to do is look at your face, because if you have sinusitis, if you have a toothache, it can cause headache. Then think about the blood. Like if you have a sickness, an illness, so something systemic can cause secondary headache. But the one that's most likely in this individual is something happening within the skull. And then whenever you say, oh, something's happening within the skull, you just take an anatomical approach. Start with the dura, the epidural space, work your way into the parenchyma, think about the vessels, think about the ventricles. To just give a couple firm examples, giant cell arteritis, cerebral vein thrombosis, meningoencephalitis, hydrocephalus, vasculitis. These are just an anatomical based approach. So now let's think about this patient. Just really quickly, cysts can be discovered, incidentally. We see it all the time on the kidneys, but depending on how many cysts there are, you might wonder, does this patient have some kind of cystic disease? And one of the most notable cystic diseases is polycystic kidney disease. And polycystic kidney disease is associated with a brain aneurysm. So it's easy to make a link between cyst and headache if that brain aneurysm ruptures. Then you say, okay, this hypodensity on the cerebellum, what did it really mean? Well, the cerebellum is involved in ataxia, because when you have insult to the cerebellum or the sensory nerves, you have ataxia. As long as the patient wasn't incoordinated, it's hard to make more progress from just a CT scan. Like, you might get advanced imaging and then the radiologist might have the DDX, but I'm not really sure what to make of that. And then add the steroids. So what happens when you add the steroids? It would be important to know the dose of steroids, but this patient has been on it for quite a while. All of you know by now that steroids suppress the immune system, specifically the cell-mediated part of the immune system. This not only puts you at increased risk of common infections, be it the typical bacteria like streptococcal pneumoniae, but it also broadens that infectious bucket to include stuff like mycobacterium, fungal, and cryptococcus. Cryptococcus is a very important consideration in someone who's been on long-standing steroids, because it can decrease the immune system, and this can cause a secondary headache or a meningitis that's subacute in nature and not acute in nature, like our typical bacterial causes of pneumococcal or Neisseria or H. flu. The other thing that steroids do is they make the vessels fragile. So you're at increased risk of bleeding when someone is getting steroids. So the steroids are problematic here. They lessen the likelihood of an autoimmune disease or a malignancy, and they really increase the probability of either an infection because of the fever. I'm running towards meningoencephalitis, and maybe it's multiple foci of infection, or a fragile vessel or blood system because of the steroids, and then superimposed bleed. So what would I do next? Like, this patient needs stat imaging. Stat imaging. This is a patient, like, you're gonna rush for the CT scan. Like, you might even call a code stroke, honestly, just to, in my hospital, I probably would. As soon as they're safe, right now they're in, like, you would want to scan this patient, and then you would want to ask the question, do I need to get an EEG? Do I need to get an LP? And the answer is probably you're heading down that route of seeing what's in the CSF. Let me just throw the mic back to Robbie, just to see what his thoughts are, if anything else he wants to add.
I couldn't agree more, Prof. Perez. I have nothing to add. Absolutely superb. I tweaked my own thinking, my reflexive thinking after you emphasized the steroids, and I was just assuming the steroids were making it harder to diagnose this condition. But you're so right that the steroids may open up a whole new world of possibilities that I don't think I was thinking about. It's such a delicate thing because we're assuming this problem started before the steroids, but it might have been a benign problem that the steroids then created into a more sinister one. That's such a great nuanced point that you made there. Thank you. All right.
Okay, so I'm gonna go to the past medical history now. Patient had atrial fibrillation, was on diltiazem and Xarelto, had diabetes and they're on insulin, Lispro and Lantus, had CAD on aspirin and atorvastatin, and hypertension, and they were on the Lisinopril. Family history: mother had colon cancer. Both parents had hypertension and heart disease. Social history: drinks 2 beers every night. They don't smoke tobacco or use any recreational drugs, and they recently moved from Indiana. with her husband. She recently moved from Indiana with her husband. And no allergies.
Thank you so much, Amal. I'll just reflect very briefly on this and pass the mic to Prof. to see what he has to say. And I think that
Robbie, I just have to go to IDR. I'll be back in 5 minutes, okay?
problem.
Sorry to
Yeah.
interrupt you, man.
No problem at all. Yeah, I'll see you in a bit. Yeah, Amal, I think that this is very intriguing context because Amal, I'm sorry, I missed this. Was she on anticoagulation for her AFib
Yeah,
or?
she's on rivaroxaban.
Roxanne, yeah, that's right. Yeah, I think that this context that we're in of atrial fibrillation and diabetes is a very common one. And so the pretest probability of having this medical history is so high that it dilutes its impact on the case, unfortunately. You would almost say the pre-existing possibility of AFib and diabetes in an older woman in the United States is so high that you would be hard-pressed to say that this pushes your calculus significantly. But again, we meet yet another red flag finding, which is that the patient is on a blood thinner, exposing us to the possibility that she would have, unluckily, a spontaneous intracranial hemorrhage before our eyes. I do think it's important to emphasize the role of diabetes in this patient despite its baseline prevalence, which is it really opens the door for a wide variety of infectious considerations, especially since she's insulin dependent, and even more so since she's been receiving steroids. And I think if you are trying to understand the kinds of infections that diabetes exposes you to a higher risk of, it's really extracellular organisms. So Amal is here, and she presented an outstanding case of a patient who had both intracellular organisms and extracellular organisms 2 or 3 Thursdays ago. And unlike I was just slowing down because I don't want to reveal the diagnosis to that case a few Thursdays ago. And so in contrast to that, diabetes really poisons the neutrophils primarily, exposing you to a whole variety of bacterial infections and fungal infections. You don't have to think too long and hard about viral infections in patients with diabetes, and tend to think less about other intracellular infections. So for me, I think the steroids and the diabetes make me pause and make me now wonder, how much do we have to expand the spotlight to think of pyogenic bacterial infections and to think about fungi? And that's where you go and you really need to know the epidemiological history of the patient, where she's from and what she does, to help you understand the fungal category especially. And I'll just leave it at that. And excited to hear what Amal has next in store.
Okay, so now for labs, I'll just start with the basic labs. So white blood cell count was 17,900. Hemoglobin was 12.4, and platelets were 151,000. For chemistry, her sodium was 123, potassium was 4.2, chloride 105, bicarb 25, BUN 17, creatinine was 0.89, glucose 127, calcium 8.4, and MAG was 2.1. AST was 42, ALT was 23, alk phos was 57, and albumin was 4.1. GFR was greater than 60, and troponins were normal, 0.
Very interesting. Amal, I don't know if you have this saved for a future Alquat, but do you happen to know were these changes that mapped onto her deterioration, or did she have pre-existing sodium or white count abnormalities beforehand, you know?
So she had a hyponatremia from on admission, and it was worse, and nephrology was following. So her Initial sodium was 119.
119. And then and her white count was new, or was that also part of what's been going on?
It's also been going on, and she's been on steroids, which
Yeah, for sure. Yeah, absolutely. And then, do you know, had she been febrile during the previous hospital stay, or is the fever also new?
the fever was also new, but she's been like slowly, her like temperature has been slowly creeping up.
Fascinating. Yeah, I think what you're dealing with now, just to understand the syndrome better, is really this idea that this has been a syndrome that has been petering on and getting worse and worse and worse, and then rapidly got worse over the course of a hospital stay. I think we're getting to the pivot point of the case, and I would hate for Prof. Rez to miss it. So why don't we do this? Why don't we do 3 minutes of breakout rooms for you all to dissect this data with a little bit more time, since I think it's very, very intriguing. And then we'll come back and talk about it as a large group. So if you are unable to join the breakout rooms, that's not a problem at all. But if you are, please hang out, chat, reflect on this case, and we'll reconvene in about 3 or 4 minutes. All right.
So Maddie, I was telling Robbie, I have a story to share. So Maddie and I, we met up for dinner last night before I went to watch Dune 2. And we picked this pizza spot, this Italian spot in Westwood Village. And Robbie, it has this like really pretty courtyard. So we go and we're like, oh, this is interesting. So we sit in the courtyard and we couldn't decide pizza or pasta. And we're like, what would Robbie do? Robbie would get both. So we ordered one pizza to split, and then we each ordered our own pastas. But then we're sitting in the courtyard, and then this band comes with like, imagine like you're in France and it's like that really like love music, like la 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 la, and they're like singing. And then Maddie and I were joking, all they need to do is put a candle in front of us. And then Maddie was like, what if they bring us a cake? And then we're like, Hirsch, Maddie's partner, and Liz, my partner, are going crazy right now. Sorry to embarrass you, but I thought that was so funny. It was like this, like setting, like it's somewhere you would take someone to propose to, basically.
It was, yeah, the music was very beautiful. The scene was amazing.
All right. So now to jump back into the, by the way, Dune 2, I never watched Dune 1, and I got tricked into Dune 2. So my colleague Will Cope texted me and my partner and his partner, let's go watch Dune 2. And I couldn't even watch Dune 1. It was too slow. So I stopped it. And then but Will and Monica, we love them. Like we party with them. We just like anything they tell us to do, we say yes. But this is where the trick happened, Robbie. The next morning, I get a text saying, hey, everyone, we'll see you at 6:45. And there's like 7 numbers I don't know. And you know me, I'm an introvert. I don't want to talk to strangers. So now I'm roped into watching a movie I don't want to watch and sitting next to someone I don't want to sit next to. Anyways. Let's get this whiteboard back on so I can dissect this case.
We had an eventful day yesterday, Prof. Rez.
And one last comment I have to make is I'm very egotistical because when I came back after this IDR and I saw only 15 people, I thought people left because Reza had left. So why should they stay and listen to any more of the conversation? All right, let's jump into this. So, you know, I think, Robbie, the additional history of diabetes, now you have 2 hits against the immune system. And both of them are impairing cell-mediated immunity. With this leukocytosis, I think really this can't be anything other than infection, like 99%. You have an immunocompromised patient on steroids for 3 months, has a history of diabetes with the worsening neurologic syndrome with a fever. And where I'm running to is a meningoencephalitis. The hyponatremia, I used to like make the hyponatremia a big deal, but not so much anymore. When I'm dealing with all this other stuff, I may use it as a clue to like what kind of organism. So for example, if this was like a primary pulmonary syndrome, I would say, oh, could this be Legionella, for example, that is more likely to cause SIADH. But the other thing I think about with hyponatremia and steroids is if that steroids was stopped and this patient had suppression of their hypothalamic pituitary adrenal axis, could they actually have adrenal insufficiency? And that adrenal insufficiency is contributing to the hyponatremia, or as we're worried about unusual organisms, could there be a disseminated infection that's also hitting the adrenal gland, like histoplasmosis, for example? I think, Robbie, we still have to run towards typical bacteria here. Like we've been fooled before. Like I think this patient needs an LP to evaluate the CSF. I would empirically treat for meningoencephalitis with vancomycin, ceftriaxone, acyclovir, and ampicillin. I would throw in Listeria coverage, but I would be wondering, am I missing something like a mucormycosis or a mold or a fungal infection or a tuberculous infection? I think I'm going to pass the mic to you, Robbie, because you taught a lot about TB and like how we used to think it's just subacute in nature. If you want to talk about that, talk about that, but anything else you want to layer on that discussion?
Yeah, Prof. Rez, as always, there's not much to layer on with the poetic Prof. Rez, and I think I'll just spend a moment on the management aspect of it, and then reflect on that question. I think in terms of the management now, when you're listening to Prof. Rez and you have a compelling case for an intra-brain infection, I think the steps are, what can I get out of blood testing? Do I need to image the patient? And then I get the LP. So blood testing, I think, is really important. About 50% of patients with pyogenic bacterial infections have a positive blood culture that can really, really profoundly help you. So the blood culture is really key in all these patients. And the question is, what else? And there's 3 tests to consider in all patients with infectious meningoencephalitis outside the blood cultures. The first is an HIV every time. The second is a syphilis, because an RPR titer that's very high can really support the idea of meningovascular syphilis. And the third, which I think is the most important one here, and the one emphasized by Prof. Rez a long, long time ago, is a serum cryptococcal antigen. Those are your insights into the possibility of infectious meningoencephalitis without even beginning to think about the actual TAP. So this is the moment where we get those tests, and then we follow that moment by then giving patients empiric antimicrobial therapy, which we'll skip over now. And then the question of imaging. Do you have to image? The bedrock for imaging in the context of infectious meningoencephalitis is this notion that if you put if you do a lumbar puncture and there's high intracranial pressure here, and you put a drain here, the brain might fall and cause a herniation. That's the premise of it. And there are many studies that evaluate who needs a CT and who doesn't. And it's controversial, but this person probably needs imaging because of the obtundation that's so acute, but it also needs imaging because she has a focal neurological finding, namely that cerebellar hypodensity. And then finally, the lumbar puncture. And I think the lumbar puncture analysis is going to be fundamental to this case, with the careful attention to how high the white count is, what the differential of that white count is, and what the glucose and protein is. And I think we can have that conversation about TB. We'll have that conversation no matter what, if and when we get those results. But I think now it becomes so key to understand this case. I think we need 2 other dimensions. The first dimension, Prof. Rez said a long time ago, is what is the time course? Is this a syndrome that's subacute to chronic? Or is this a syndrome that actually was completely benign and then the steroids made it an acute syndrome? So subacute, ongoing versus acute induced by steroids. And then also, what is the center of gravity? Is this isolated infectious meningoencephalitis, or is this a systemic disease with brain manifestations? And I think that's the tension of this case. Are the hepatic and splenic, not hepatic and splenic, yes, hepatic and splenic cysts, are they benign cysts, or are they a clue to the systemic fingerprint of this disease process? So to give you an example of acute isolated, it would be Cryptococcus. Acute systemic, pyogenic bacterial infection. Subacute and isolated, Cryptococcus. Subacute and systemic, endemic mycoses. So which way how we draw this table is going to be very, very key. But honestly, what I'm most interested is in, of course, the CSF studies, but also attention to what is the time course and what is the lay of the land. And you can make a 2x2 table that really filters the differential diagnosis significantly. Alrighty, Amal, tell us more. What do you have next?
Okay, so next I'm gonna go to the imaging. So EKG showed normal sinus rhythm. Chest X-ray showed diffuse interstitial opacities. And then CT, echo was unremarkable, sorry. CT, so I have images of the CT brain that we did after. So I'm gonna share my screen. Can you guys see my screen?
Yeah, looks great. Thank you.
So this is the CT brain.
Mm. Mm.
And it was read as extensive. So there's like an extensive enhancement, hyperintensity, that's diffuse. And that seems to be deteriorating, like worsening compared to previous CT brain.
I must confess, I'm so ignorant. To me, this looks like an MRI. Do you
Oh,
know?
sorry. This is the
That's
So
okay.
it says restricted diffusion along posterior limbs of internal capsules, right thalamus and pons, hydrocephalus, layering fluid in occipital horn.
Awesome. Prof. Rez, I rambled a lot. I'll pass the mic to you, my friend.
Thanks, brother. First of all, Alma, thanks for bringing the picture, and thank you for reading. More importantly, thank you for reading the interpretation, because I was like, oh, is that a cyst? Like, right, my diagnosis was gonna be, is that a little cyst there in that right upper section? But what this does, so I think the main findings is the following. We have enhancement, we have diffusion restriction, and we have hydrocephalus. Whenever you see enhancement on an MRI, it's because you've given gadolinium and that there's a breach in the blood-brain barrier. Because the blood-brain barrier keeps the GAD out, like it won't let it enhance, the surrounding tissue. So whenever there's enhancement, know that there's been a breach in the blood-brain barrier. The question becomes, what is causing the breach? And I'm going to lump in the diffusion restriction here too, because it's really inflammation. Though we had a case on RLR where it was actually trauma that led to that disruption and abnormal imaging findings. So inflammation, just go back to fever, the eye-made mnemonic. That's where we are, folks. Infection, malignancy, autoimmune. Autoimmune is very unlikely in this case, just based on all the background data. And I really can't think of anything that would do this in the brain that's autoimmune in nature. So it's really infection or malignancy. And honestly, in malignancy, it's only one cancer that could do all this. And that would be a lymphoma that can mimic a disseminated infectious process. But really, the question is, what infection? And so I think the infection is disseminated. I think it's breaching the blood-brain barrier. And it's a type of infection that is causing hydrocephalus. And when you think of hydrocephalus, just think, where does the CSF produce? Where does the CSF have to travel to? And where is the CSF drained? Imagine like a faucet in a bathtub. You turn on the faucet, that's the production. You have a drain at the end and it has to come out somewhere. And the tub is the ventricles. In this, Robbie, I came out because Curbsiders had an episode about gout and uric acid. And I just wow, I'm really proud of myself. Okay. So in this case, we know there isn't any obvious evidence of what's causing obstructive hydrocephalus. So you worry about what infections like to do that. Well, one we mentioned is Cryptococcus. Cryptococcus, it causes something in the arachnoid villi from having difficulty reabsorbing the CSF that's being produced. And for some reason, patients with cryptococcal meningitis, think about it. They have high pressures, but we still do an LP in them. It doesn't cause herniation. I asked Aaron Berkowitz this question once. I just don't remember his answer, which means he didn't give a good answer because I don't remember it. Other infections include mycobacterial and fungal. And Robbie, I think we were at the base of the brain, because of that absent gag reflex. I think that's such a striking finding to me. I'm just really worried about basilar meningitis. And I don't have the best schema for that. I would love to hear from you. What infections I know you can incorporate all the data, but specifically for basilar men, like how do you think about that in terms of organisms?
Yeah, Prof. Rez, I completely agree with your take. I mean, this is a basilar meningitis, and I think that the word basilar meningitis is really equivalent equivalent to subacute infectious meningoencephalitis. And the idea being that there has been inflammation in the meninges for so long that you start to develop compressive features of the things that exit the brainstem. You start to compress the cranial nerves, and so you can get a cranial neuropathy. And then you start to compress the vessels, resulting in the strokes that this patient has. And then you start to compress microscopically the arachnoid villi such that you get hydrocephalus. So the hydrocephalus, the infectious vasculitis, and the cranial neuropathies are all reflective of the time course. So this MRI alone tells you what the time course is. This is not acute. There's no way this is acute. Because if it were acute, you would not have time to develop the strokes, have time to develop the hydrocephalus. So just on the MRI alone, we can now go back to our table and say this is subacute meningoencephalitis, evocative of basilar meningitis. And so now the remaining question is this a systemic disease with subacute meningitis, or is this an isolated CNS disease? And I think it can be so easy to be fooled into it's an isolated CNS disease because the CNS is so distracting. The patient's obtunded, they got so much going on. A quick survey of the systemic circulation is going to be key, but I think one key variable is the patient's not hemodynamically systemic. And if we're saying that the brain is so sick in a subacute way, and yet the blood pressure is normal, maybe gives us a clue that our problem representation should be that this patient has an isolated subacute meningoencephalitis. And the word isolated subacute meningoencephalitis really restricts the differential diagnosis to the infections that have a profound tropism for the brain. Yesterday's problem representation was profound tropism for the pituitary, and today is profound tropism for the meninges. And that's where I think this case screaming cryptococcus until proven otherwise. Of course, there are other things that can do it, but I think that's your suspicion of that early on, I think is really bearing fruit. And it would be key in this patient to consider it very quickly, because the morbidity of cryptococcus in this circumstance is probably very high.
Robbie, can I ask you, that was beautiful. Can I ask you what species?
Yeah. Oh my gosh. Professor, the truth is that I learned a lot about this because of an ID grand rounds I went to. There are many species of Cryptococcus, but for our purposes, there's two. There's Cryptococcus neoformans and Cryptococcus gattii. And Cryptococcus, the fundamental difference between Cryptococcus neoformans and gattii is really down to geographic distribution. Gattii is much more geographically restricted, historically just in the Pacific Northwest and in Australia and New Zealand, but now is more recognized to be in many other places. The other difference is that gattii is much more likely to occur in immunocompetent patients than neoformans is. Here, I think the patient doesn't have exposure to gattii based on her location in Indiana. And as you said already, she's immunocompromised from her diabetes. So neoformans is much more common, much more widespread, and is probably a better bet in a patient who hasn't had the geographic exposure and is immunocompromised. Yeah, really interesting bug, and a very devastating one. I'm hoping that's not the case, but I got late to the suspicion, Prof. Rez. Cryptococcus only crossed my mind a few minutes ago, but it crossed yours a few hours ago, it seems like. I'll pass the mic to you, Amma. What's next?
So after the MRI brain, we did CT, chest, abdomen, pelvis. And let me try. Sorry. Oh.
As we're pulling up the image, Robbie, did you have your coffee yet?
Where's Prof. Rez? Of
Man,
course.
I can't wait to have mine. I haven't had mine yet.
Whoa, this is
Can
Prof.
you
Rez.
guys still see my screen? Because my Zoom is
Oh no, not yet, unfortunately. Well, not yet.
computer froze.
Gosh. we're probably going to have to, based on your efforts, we're probably going to have to change our problem representation to a subacute systemic. Uh, oh man, this case is
Okay.
take your time on it's okay. Professor, you have to go at 8.
No, I have some time at this point. The morning report's 8:15, so
Okay.
I'm good.
Awesome.
Oh, how about you? Do you have to go right now?
I have to be at my dentist at 9 o'clock and I have to leave in 20 minutes. So
Okay.
I'll take all the time you need. Maybe I don't have to go to the dentist if, if we're delayed.
I might need to leave and come back. Is that fine? Because my
Oh, it's okay. You can just tell us the report.
Yeah, just tell us, Alma. That's
Just tell us the
okay.
report.
Oh,
We have no idea what we're looking at half the time.
the CT chest, abdomen, pelvis showed acute on chronic inflammatory process in the lungs with left lower lobe bronchopneumonia, no acute inflammatory process in the abdomen, pelvis.
Awesome. Yeah, I think that I don't think this changes the problem representation too much because all the organisms that we were talking about come from the lungs. And I think we were most interested in seeing what the representation of it was in the belly. Did it really go both to the brain and the belly? And the fact that there's lung process that is being sucked so profoundly towards the brain rather than disseminating in the liver, spleen, and most importantly, the lymph nodes, I think really says that this is a subacute brain predominant disease. But that's where I'm at. Where are you at, Prof. Rez?
Well, where I'm at is in the chat where there's like only in the CP solvers chat will there be an argument about neoformans versus gadii. But I have nothing to add. Almo, back to you.
Okay, so LP. So we did LP and the cells, 535 nucleated cells with differential of 6% lymphocytes and 89% neutrophils. More than 200 milligram per deciliter of proteins and 17 milligram per DL of glucose. 17. And then we did a meningitis encephalitis biofire panel, which includes most of the viral and bacterial organisms, and that was negative.
Very good. And did you have an opening pressure, Amal, on that?
Yeah.
If not, that's okay.
I don't have it
No
written down.
problem. The only reason I was asking about that is when you are worried about cryptococcal meningitis, it's another factor that can help in supporting that hypothesis, though it's not the only cause. So even if the patient had opening pressure that was elevated, you can't say it's cryptococcal. There's other etiologies. I think just quickly interpreting this is that what's most striking to me is the neutrophil predominant nature of the pleocytosis and the hypogalacto something, the low glucose in the CSF. Robbie, say it for me.
I have no idea what it is, Prof. Rez.
No, you do. You're just.
I didn't say low CSF. Honestly, I have no idea. Low CSF glucose.
Someone, Noah, say it. Someone say it in the chat. So low CSF glucose. When you have low CSF glucose, it's telling you that, I mean, a simple way of thinking about it, but I don't think this is mechanistically accurate, but it's a simple way of thinking about it, that you have some organism that's eating up the glucose. And those organisms often are either mycobacterial or fungal. I think what the neutrophil predominance does for me is maybe decreases the process a little bit on cryptococcus. Maybe those often cause a lymphocytic pleocytosis, but it's really important when you're doing clinical reasoning to be okay to like one value not being exactly what you expect it to be. So for me right now, the high protein, the low glucose, the neutrophil predominant, the subacute course, it's fungal or mycobacterial until proven otherwise.
I completely agree, and I think that's the key question in this case: is have they been proven otherwise with the extensive PCR testing that Amal just reported? Amal, is it really? You said it viral, bacterial. Is it also fungal or?
No, it's mainly viral and bacterial.
Gotcha. Yeah, I think. Yeah, I think that right there with you, Prof. Rez, I think viral and bacterial with multiplex PCR are much less likely, and I think. Yeah, I think what is the real value of neutrophilic pleocytosis in general? I think it just has a much narrower non-infectious differential diagnosis. When you look at lymphocytic pleocytosis, all the non-infectious things are totally fair game. So the first step in comparing neutrophilic pleocytosis and lymphocytic is to realize that the non-infectious differential diagnosis is so much narrower. And it includes really cool things, which we don't have time to talk about, but it's very small. So the infectious differential diagnosis is really still viral if it's early, bacterial pyogenic if it's very high, over 1,000, fungal, especially fungal disease in a relatively immunocompetent host, and then parasitic diseases, and of course, amoebic diseases. So neutrophilia is really, really complicated and has to be merged, I think, with the time course and with the parenchymal findings. So for example, in a patient with amoebic neutrophilic pleocytosis, they will always have many brain abscesses, which this patient does not have. In parasitic diseases like toxoplasmosis, exactly true. Their brain MRI will show parasitic diseases. In fungal, you probably won't have as many overwhelming MRI findings. So here, I think, Prof. Rez, I'm right there with you that that viral and bacterial have been nearly definitively excluded. And I think it further raises the concern for Cryptococcus in my mind. All right, Emma, what do you have next?
Okay, so not to surprise you guys, but Cryptococcus was negative. Like the extensive workup for Cryptococcus was negative.
Awesome.
So so we did bronchoalveolar lavage. And because of the pulmonary, because the CSF wasn't growing anything for days. So we did a bronchoalveolar lavage, with at some point grew budding yeasts. But only what it showed. So what we did is we ordered a urine histoplasma antigen, and that was positive.
Wow.
So yeah.
Very, very interesting. I have so many thoughts to share, but I don't want to ramble too much. Prof. Rez, I just chatted a little bit. What are you thinking?
Oh, I think this is just one, it was a brilliant presentation. I think it's just, like you can't really, I feel like we did it justice, our discussion was exactly where we should be. We said Cryptococcus, but we said it could be any fungal infection. So am I surprised? No, I'm not. Like, I think we had impaired cell mediated immunity. You had this low glucose, like we thought, yeah. So I was just most intrigued by the way you presented the case and how quickly stuff developed and how much you had to do to actually get an answer. Very good job, Amal. Thank you for this fabulous hour. And I'm going to give the mic to Robbie, and then we'll give it back to you to
Yeah, no, I think it's so well said, Prof. Rez. I think this is a very, very humbling and extremely educational case. And I think it goes to show you how you have to be very, very careful in patients with headache syndromes, and be very, very careful not to muddy the waters with empiric treatment when you don't really have a grasp of what's going on. And I think it's an open question of whether she had a mild headache problem that was turned into histoplasmosis, or whether she had histo to begin with. But I think the adage is true, is when you have a subacute CNS, when you have a subacute meningoencephalitis, really, really restricts the differential diagnosis to a lot of the atypical organisms, including all the fungi. I'm a little bit surprised that it's histo, not crypto, because of the tropism this infection seems to have had for the brain. Histo can go to the liver and the spleen, and I wonder if the splenic cysts, in retrospect, were more significant than my reflex to minimize their significance. And of course, the residence in Indiana. But absolutely fantastic case. Really, really fun to share all the learning with us. And I love that you presented a really cool esoteric case, but started with the bread and butter of an ICU patient who is obtunded, teaching us how to take care of patients practically, but also to stretch our clinical reasoning. Really, really cool exercise to do that. Thank you. What were your thoughts?
Yeah, so it was very interesting for me. I'm actually this is one of the most interesting cases, because it took like a week or two to find the diagnosis. And then I was so shocked after to find out that it was disseminated histoplasmosis. We asked the husband, and apparently they were like building a roof together. And I know histoplasmosis is like is inhaled, and it's usually like in soil and stuff. So I kept wondering, and because they were in Indiana, so in retrospect, I was like, oh, like maybe, yeah, now this makes sense, but it wasn't on our top differential when we were working her up. But yeah, I really enjoyed presenting this case today, and thank you so much for having me.
It's an absolute pleasure. An absolute pleasure. Thank you so much, Amal. All right, Tansu, mic to you for the teaching points.
Thank you, Rabih. Amazing discussion. And thank you so much, Amal, for bringing this very humbling case to us today. So we started off with a 60-year-old female patient who was obtunded in the ICU. And when we think about obtundation, we have to think about the tempo. And hyperacute syndrome, neurologic syndromes brings to mind the 3 S's: sugar, seizure, stroke. Acute time course points towards inflammatory and infectious causes, and toxic and metabolic causes can have any time course. In hospitalized patients, obtundation is kind of worrying, because the only way a hospitalized patient can be this obtunded if they didn't give us enough time to interfere with their disease process. So we thought that in this patient's case, probably her time course was pointing more towards hyperacute. And we have to look at other clues to find if this is a neurologic disease or a systemic fingerprint, if it has systemic fingerprint and a systemic disease causing neurologic deficits. For that, we looked at the vitals and neurological exam. The patient was febrile, so that made us prioritize infectious meningoencephalitis, but we should, of course, keep searching for infectious foci somewhere else as well. And non-infectious causes are also possible. One example to that would be neuroleptic malignant syndrome. The patient didn't have gag reflex, so we understood there's a brainstem issue, and she had positive Babinski that pointed us towards more like an upper motor neuron type of disease. And Prof. said this could be possibly a basilar meningoencephalitis with the lack of the brainstem reflex, the gag reflex, and Babinski positivity. And since this patient had both brain and lung issues, we had to think about which one came first, brain or the lung. Here it helps us, what helps us the most is like which one is more down, the brain or the lung. And in this case, the brain was more down. So we thought that a neurological event is pointing towards a pulmonary syndrome. And we have to quickly scan the patient in this case because of the altered mental status. And we remember the scan mnemonic that Andrew shared with us recently, actually a couple of VMRs ago. So we have to check the sugar, get a CT, and ABG, VBG, and since hospitalized patients use opioids, we have to consider giving Narcan to those patients. And while differentiating primary versus secondary headache syndromes, we have to search for extra headache signatures, check the 4Ts, which are trauma, thinner, meaning blood thinner, and timing, and triggers. And then we can take an anatomical approach to the brain structures from dura, vessels, ventricles, and parenchyma of the brain. And this patient was given steroids, which suppresses the immune system that broadens the infectious bucket. And steroids also makes the vessels fragile. So this could be, this could have been an subarachnoid hemorrhage, like a vessel issue. And the patient's past medical history of diabetes opened up possibilities of extracellular organisms, because too much sugar in our bloodstream poisons the neutrophils, makes us more prone to extracellular organisms. And then we also have to think about management in such acute patients. So we have to get imaging before LP in this case, because there was a focal neurologic finding and cerebellar hypodensity and obtundation. And in blood testing, we learned from Rabih that 50% of the patients with pyogenic infections has positive blood testing. So blood testing is crucial here. We should also get 4 tests: HIV, syphilis, serum crypto antigens. And whenever we are thinking of a neurologic disease but can't decide whether a systemic disease diseases affecting the brain, we should make a 4x4 table, 2x2 table with the time course and the center of gravity. So time course wise acute and subacute, and center of gravity wise intracranial versus systemic. The gadolinium enhancement in the MRI of this patient's MRI made us think that there's a disruption in the blood-brain barrier. And in the MRI, we also know that the obstructive hydrocephalus, and there are not very many organisms that causes obstructive hydrocephalus. We have to think about crypto, mycobacterium, and other fungus. And we decided in the end that this patient has probably a subacute basilar meningoencephalitis, but the LP, the CSF cultures didn't grow anything. We checked the BAL, which showed budding yeast, and finally the diagnosis was revealed by the urine histoplasma antigen positivity. That's all from me. I hope you all have a wonderful Friday.
Kansu, that was unreal. I think we all feel the pressure of having to speak much faster when we're running behind, and both Reza and I did that. But you somehow managed to stay cool, calm, collected, and deliver those teaching points with such poise.
Can I just say, like, that she like took at least my teaching points and made them better and more memorable. Kansu, never do that again. Don't embarrass me like that on VMR.
Big shout out to Francisco too with the epic scribing on a very, very complicated case. Thank you so much, Francisco. But of course, a biggest shout out to our case presenter, Amal. We really, really hope that you'll be back with more ID and non-ID bonanzas. It was really nice to have you here. Thank you very much.
Thank you. Thank you.
Bye, guys.